Sinus node dysfunction. Etiology of sinus node dysfunction, SND. SND may be due to intrinsic or extrinsic causes. Intrinsic causes. Idiopathic degenerative disease, the most common. Ischemic heart disease. Hypertension. Myocardial diseases, cardiomyopathy, amyloidosis, sarcoidosis, musculoskeletal disorders. Collagen vascular diseases. Congenital heart disease, for example, sinus venosus and secundum atrial septal defects, even without surgical repair. Surgical trauma, responsible for pediatric cases of SND, for example, Mustad's procedure and repair of atrial septal defects. Orthotopic cardiac transplantation with atrial anastomosis, likely because of sinus artery damage. Extrinsic causes. Drugs directly affecting the nodal tissue, or indirectly by neurally mediated effects, for example, beta blockers, calcium channel blockers, digoxin, clonidine, and antiarrhythmic agents, classes 1A, 1C, and 3. Excessive vagal tone, for example, carotid sinus syndrome, neurocardiogenic syncope, and in well-trained athletes. Electrolyte abnormalities, for example, hyperkalemia, hypothermia, elevated intracranial pressure. Arterial blood gases abnormalities, for example, hypoxia, hypercapnia, hypothyroidism. Advanced liver disease. Infections, for example, typhoid fever, brucellosis, and sepsis. Clinical manifestations of SND. Age. Most patients are over 50 years, and progression is usually slow. Clinical documentation of SND may be difficult since the symptoms are nonspecific. Common symptoms: effort intolerance, dizziness, presyncope or syncope, especially in sick sinus syndrome with long pauses after termination of supraventricular tachycardia. Stroke may be the first manifestation due to paroxysmal atrial fibrillation. Prognosis depends on the type of dysfunction and underlying heart disease. Sinus bradycardia is usually benign, while sick sinus syndrome carries the worst prognosis, mostly due to thromboembolism from AF. Incidence of thromboembolism in SSS. It is of particular importance to realize that the incidence of thromboembolism in unpaced patients with sick sinus syndrome is very high, 15%. Little decreased with right ventricular only pacing, 13%. But much reduced with dual chamber pacing, 1.6%. Likewise, the incidence of new atrial tachyarrhythmia in sick sinus syndrome with right ventricular only pacing is very high, 20%. Which is much reduced with dual chamber pacing, 4%. Conduction system disease in patients with sinus node dysfunction. Some degree of atrioventricular conduction system disease is found in about 17% of patients with sinus node dysfunction, and new atrioventricular conduction abnormalities develop at an incidence of 3% per year in these patients. Meanwhile, advanced atrioventricular block develops at an incidence of 1% per year. Thus, association of sinoatrial and atrioventricular node disease is common. If one node is diseased, it is imperative to study the function of the other node. Electrocardiographic testing of sinus node dysfunction, SND. Diagnosis of SND, as the cause of the symptoms, is rarely made from the surface ECG. 24 or 48-hour ambulatory Holter or cardiac event monitoring, or implantable loop recorders, can exclude SND as the cause of symptoms, if normal sinus rhythm is documented at the time of symptoms. In contrast, sinus pauses recorded may not be associated with symptoms. Exercise testing to assess chronotropic incompetence is of value in patients with exertional symptoms. ECG manifestations of SND. 1. Sinus bradycardia. 2. Inappropriate sinus bradycardia, chronotropic incompetence. 3. Sinus arrest. 4. Sinoatrial block. 5. Sick sinus syndrome. 6. Persistent atrial standstill. Sinus bradycardia, SB. SB is defined as a sinus rhythm at a rate below 60 impulses per minute. Its significance is much more dependent upon clinical circumstances rather than the absolute rate. Sinus bradycardia is commonly accompanied by some degree of sinus arrhythmia. It may be normal even at rates in the mid to low 30s in highly trained young athletes at rest. Significant SB. SB is considered abnormal and significant in any of the following conditions. If persistent and unexplained. If inappropriate for the physiological circumstances. If heart rate is less than 40 beats per minute, if not during sleep or due to extreme physical conditioning. This is a schematic ECG in sinus bradycardia. Inappropriate SB. Inappropriate sinus bradycardia, chronotropic incompetence, is defined as inability to achieve at least 85% of the maximum age predicted heart rate during exercise testing, or inability to achieve a sinus rate of at least 120 beats per minute at maximum effort. Sinus arrest. Sinus arrest is defined as failure of the sinus node to fire the impulse. Sinus arrest may not be differentiated from sinoatrial, SA, block in surface ECG, but the presence of a pause equal to exact multiples of the sinus cycle length favors SA block over sinus arrest, because on sinus arrest the sinus node may recover at any time, unlikely exactly at its firing time. Thus, the pause in ECG is sinus arrest is unlikely to be an exact multiple of the preceding PP interval, but is random in duration. Asymptomatic pauses up to 3 seconds can occur in 10% of normal individuals and 30% of trained athletes. Pauses greater than 3 seconds are usually caused by SND, rare in normal individuals, and may or may not be associated with symptoms. Systematic approach to determine the cause of pauses in surface ECG. When P wave is present in the pause and premature, it may not be followed by QRS, blocked premature atrial contraction, PAC, or followed by narrow QRS, normally conducted PAC, or followed by wide QRS, premature ventricular contraction, PVC or aberrant PAC. When P wave occurs in time in the pause but not followed by QRS, this is atrioventricular, AV, block. If the P wave is absent, this is sinus arrest or sinoatrial, SA, block. Thus, the differential diagnosis of ECG pauses is 1. Blocked premature atrial contraction, blocked PAC premature P wave not followed by QRS. 2. Normally conducted PAC, premature P wave followed by narrow QRS. 3. Premature ventricular contraction, PVC, versus aberrant PAC, premature P wave followed by wide QRS. 4. Atrioventricular block, P wave in time and not followed by QRS. 5. Sinoatrial block versus sinus arrest, absent P wave and QRS complex. Sinoatrial, SA, block. Sinoatrial block, SA block, is defined as block of the impulse that arises from the sinus node, and does not conduct out to depolarize the atria. SA block may be due to delay in conduction or block within the sinus node itself, or in the perinodal tissue. The whole PQRST complex will be missing. The pause created, in theory, is an exact multiple of the baseline PP interval, because the sinus node continues to fire in time, and conduction will resume after block resolution. In practice, sinus arrhythmia causing normal beat-to-beat variations, often makes distinction from sinus arrest impossible. P wave is absent. Pause is not a multiple of the sinus cycle, excluding SA block. Diagnosis: sinus arrest. Types, degrees, of SA block. 1. First degree SA block. 2. Second degree, partial, SA block. A. Type 1, Wenckebach, second degree SA block. B. Type 2 second degree SA block. 3. Third degree, complete, SA block. First degree SA block. Definition: abnormal prolongation of the sinoatrial conduction time. It is concealed in surface ECG, and can only be diagnosed by direct sinus node recording. or indirect measurement of sinoatrial conduction time during EPS, discussed earlier. Type 1, Wenckebach, second-degree SA block. Understanding this type of block is possible only after discussion of the characteristics of the Wenckebach phenomenon. The Wenckebach phenomenon. Wenckebach block is classically described at the atrioventricular AV junction, but occasionally occurs at the sinoatrial junction, and rarely in the His-Pourquenier system. It is characterized by the presence of decremental conduction, manifested as gradual prolongation of the impulse conduction time, until an impulse is blocked, and the cycle is repeated. To understand the Wenckebach phenomenon, it is advisable to consider first the AV Wenckebach, since the AV conduction time can be calculated in the surface ECG as the PR interval, taken from the start of P wave to the start of QRS complex. This calculation is possible thanks to the presence in the surface ECG of a wave representing depolarization of the proximal chamber, the atria, which is the P wave, and another wave representing depolarization of the distal chamber, the ventricles, which is the QRS complex. This chance is not available in the case of SA block, since the proximal chamber, the sinus node, has no representing wave in the surface ECG. Calculation of the SA conduction time from the surface ECG is thus impossible. 5 characteristics of typical atrioventricular AV Wenckebach block are described. 1. Decremental conduction seen as gradual prolongation of the PR interval, until one P wave is blocked, not followed by QRS, then cycle is repeated. 2. Pauses between the QRS complexes, resulting from the blocked beats. The duration of the pause is less than the sum of any 2 cycles between conducted beats. 3. Group beating, resulting from the pauses, a group of beats followed by a pause, followed by another group of beats, and so on. 4. Gradual shortening of the ventricular, distal chamber, cycles, the RR intervals. 5. The first PR interval in a group, post-pause, is shorter than the last PR interval in the previous group of beats, pre-pause. These characteristics will be discussed in more details under AV block. Now, let us go back to SA Wenckebach block. Obviously, the criteria concerned with the conduction time in AV block, PR interval prolongation, and relation between pre-pause and post-pause PR intervals, cannot be applied to SA block, because the SA conduction time cannot be calculated as mentioned earlier. It follows that SA Wenckebach, or type 1 second-degree SA block, is characterized in the surface ECG by the remaining 3 criteria. 1. Pauses, but now between the P waves, which are usually less than the sum of any 2 PP intervals between conducted beats. 2. Group beating, resulting from the pauses. 3. Progressive shortening of the atrial, distal chamber, cycles, PP intervals, until a full PQRST cycle fails to occur, and the process is repeated. Type 2 second-degree SA block. Definition: an abrupt absence of one or more P waves, and QRS complexes, without previous progressive shortening of the PP intervals. Theoretically, the sinus pause should be an exact multiple of the immediately preceding PP interval, but sinus arrhythmia can disturb this measurement. To summarize, in type 1, Wenckebach, SA block, there is gradual shortening of the PP intervals, and the pause is less than 2 cycles. In type 2 SA block, the PP intervals are fixed, and the pause is equal to 2 cycles. Upper, type 1 SA block, group beating, and pause less than 2 cycles, gradual shortening of PP intervals. Lower, type 2 SA block, group beating, pause equals 2 cycles, and fixed PP interval. Third degree, complete, SA block. Third degree, or complete sinoatrial block, manifests as absence of the whole PQRST waves, with long pauses. It may be transient, or may result in syncope, or even death, if no escape rhythm emerges. This type of block is impossible to distinguish from sinus arrest with certainty, without invasive sinus node recordings. 6. Sinus syndrome, SSS. The sick sinus syndrome, or the tachycardia-bradycardia syndrome, presents as supraventricular tachyarrhythmia, alternating with sinus or junctional bradycardia. The tachyarrhythmia is most commonly paroxysmal atrial fibrillation, but atrial tachycardia, atrial flutter, atrioventricular nodal reentrant tachycardia, and atrioventricular reentrant tachycardia can also occur. On spontaneous termination of the tachyarrhythmia, or after electrical cardioversion, prolonged sinus arrest and asystole may occur, due to transient suppression of the sinus node during the period of tachycardia. This schematic represents atrial fibrillation, AF, in a patient with sick sinus syndrome, followed by a prolonged pause after its termination, before the appearance of a sinus beat, and recurrence of sinus rhythm. Persistent atrial fibrillation, with a slow ventricular response, in the absence of AV node blocking drugs, is also common in patients with sinus node dysfunction. Ventricular response may become rapid during exercise. These patients may also develop complete AV block, with a junctional or ventricular escape rhythm. A combination of sinus node dysfunction, SA block, and AV block, can be present in many patients. It is a general rule that, in the presence of either node disease, test the function of the other node. Persistent atrial standstill. Atrial standstill is a rare clinical syndrome in which there is no spontaneous atrial activity, because the atria are fibrotic, and cannot be electrically stimulated. Lack of mechanical atrial contraction poses a high risk for thromboembolism. ECG usually reveals junctional bradycardia, without atrial activity. Thank you.